welcome. And again, thank you so much for joining us. Today is the first webinar in our Value of Diagnostics Within Women's Health series, entitled How Vaccines and Screening Can Prevent Cervical Cancer. I'm Katie Schubert. I'm President and CEO of the Society for Women's Health Research. And SWHR is the thought leader in promoting research on biological sex differences and improving women's health through science, policy, and education. We are pleased today to have two very distinguished panelists joining us for this event. Dr. Debbie Saslow, who is Managing Director of HPV and GYN Cancers at the American Cancer Society, and Dr. Carolina Aristizábal, who is an occupational health physician and the manager of the Office of Community Outreach and Engagement at the USC Norris Comprehensive Cancer Center. I'd also like to thank Roche, who is the sponsor of today's event. As always, we are live tweeting, so please join us. You can use the hashtag SWHR Talks Diagnostics and SWHR Talks Cancer as we live tweet. Again, join that conversation. And at this time, I would like to introduce SWHR's Chief Science Officer, Dr. Irina Ninye, who's going to be moderating today's event.
Thank you, Katie, and welcome everyone. Spanning from simple blood tests to X-rays to invasive procedures, modern diagnostic tests and procedures are an essential part of clinical care, aiding in the detection and monitoring of diseases and informing treatment decisions. Innovations in diagnostics can provide access to valuable information to help women make informed decisions about their health care across every stage of their lives. The SWHR Value of Diagnostics Within Women's Health series will highlight the importance of advances in diagnostic technologies and approaches throughout the lifespan, with a focus on how we can improve health outcomes for women, particularly relating to cancers, reproductive health, and bone health. Our series starts today with our focus on cervical cancer. Cervical cancer is had once been the highest cancer mortality rate among women in the United States. Overall incidence and death due to this cancer have significantly declined, in a large part to vaccination and screening efforts. However, cervical cancer is still the fourth most commonly occurring cancer in women globally. A comprehensive approach to eliminating cervical cancer includes primary prevention through HPV vaccination, secondary prevention, which involves screening and treatment of precancerous lesions, and tertiary prevention, which is the treating of invasive cancer. Incorporating diagnostic and screening tests at key time points throughout a woman's life is absolutely critical to diagnosing and treating cervical disease in the early stages. I'd like to introduce Dr. Debbie Saslow, who will share more about cervical cancer prevention and screening guidelines, including advancements in diagnostic tests and procedures that every woman in her healthcare provider should be aware of. Thanks for joining us, Dr. Saslow.
And thanks so much for having me. So I'm going to be talking about cervical cancer screening. And I will mention, adding on to the comments and the slides that you just saw, that if we can combine that primary, secondary, and tertiary approach to cervical cancer, this could actually be the first cancer that we eliminate, which would be that's quite a goal if we can get to that as we should. So next slide, please. So almost all cervical cancer, and this is a cancer of the cervix. The cervix is the lower part of the uterus. Almost all cervical cancers are caused by the human papillomavirus. So there are 6 cancers caused by HPV, and then another type of cancer, for example, that's caused by a virus would be liver cancer caused by hepatitis B. So there are many, many, many types of human papillomavirus, and a little more than a dozen of these types have the capacity to cause cancer. HPV, including the cancer-causing types, are extremely common. Almost everyone will get an HPV infection at some point in their lifetime. Next slide, please. So these are our screening guidelines from the American Cancer Society as a summary. And I'm going to go through the different pieces of these in the next several slides. But if I had to summarize it, I'd say women or others with a cervix who are between the ages of 25 and 65 should get an HPV test every 5 years. Pretty simple. There are some caveats to that. So for example, right now, today, only about 1 to 2% of all cervical cancer screening in this country is done with an HPV test. Almost all are done with both the HPV and the Pap test, and a smaller percent are done by the Pap test alone. And while you would think that it would be pretty easy to say, well, if we're already screening most people with a Pap plus HPV, let's just drop the Pap, it's actually a lot more complicated than that. Next slide. So until 2020, the American Cancer Society recommended that screening start at age 21, and some of the other guidelines that you may be aware of still start at 21. It's just a matter of timing. The other groups that do national guidelines have not yet reviewed and updated their guidelines and will be doing that soon. And so we look at all of the data, how many people get cervical cancer before age 25. That number has gone down every year, and last count was 2017 and the number was 70 and still going down. And those cancers really are not detectable by screening. There is something special about them. So start at 25, that's actually welcome news to a lot of young people, including my 21-year-old daughter. Next slide, please. And then what test to use? The HPV test. Next slide. So HPV testing has been used with the Pap test for the last 20 or so years. And what we know is that the Pap test is clearly inferior to the HPV test. For women who are vaccinated, and when I say women, I mean women and individuals with a cervix. That includes transgender men who have a cervix and non-binary individuals. It does not include women who've had their cervix removed as part of a hysterectomy. For women and others with a cervix who've been vaccinated, that group is now aging into the 25 and over. Pap tests are almost completely ineffective on somebody who's been vaccinated. And finally, we've been doing all of this Pap plus HPV, which is also called co-testing. And really, we know that when you test with both the HPV and the Pap, the HPV is doing all the work and the Pap test really isn't contributing. And that's why we are looking at transitioning to just using the HPV. Next slide, please. How often to test? Every 5 years. This number has not changed in at least 10 years. It used to be every 3 years. It's still every 3 years if the Pap test is used alone, but hopefully that's not being done very often. Next slide, please. When to stop screening. So as long as women and others with a cervix meet certain criteria, including recent screening with normal results, then they should stop screening at age 65. Women do get cervical cancer after age 65. That is still a burden. However, usually that's in either people who have not been getting screened or in somebody who had an abnormal result that didn't get followed up. Next slide, please. And again, people who don't have a cervix don't need to be screened for cervical cancer. It's unfortunate that I still need to say that. I don't know what the recent numbers are, but back when we looked at this 10 years ago, there were still well over 10 million people who had their cervix removed for hysterectomy and were still getting screened. Next slide, please. Now, this American Cancer Society 2020 guideline was really precedent setting because it predicted what our next guideline would be in the future. And it said that we would be eliminating co-testing and cytology alone. Next slide. And the reason why we plan for the future is, again, because most women don't yet have access to using the HPV test. They do have access to co-testing and PAPs, and we wanted to really let it be known that neither of these screening approaches will be included in our next guideline. But we are going through a transition process. We didn't want to say immediately, this is what we're going to do, and have the country go into an uproar because nobody had access and nobody was prepared. So we have a very large multi-year transition process that we are leading right now. Next slide, please. Also in the future, we know that the FDA is reviewing self-collection or self-sampling for the HPV test. You can't do self-sampling for the Pap test, so you can't do it for co-testing, but we expect that hopefully the FDA will approve this in the near future, and this will really help us with some of the disparities. There are a lot of people who can't access a clinician's office. They could do self-sampling in the provider's office, just like urine testing. They could also do it at home if this pandemic keeps going on. That really helps to be able to do more tests from home. Next slide, please. And I will say, don't use the non-FDA approved test. Yes, you can get it on Amazon. It is not recommended. It is not validated. It is not clinically relevant. Please don't do this. We will also be monitoring for when more and more people are vaccinated and are aging into this 25 plus group. We will be looking at whether we can make different recommendations, such as starting screening even later. Next slide, please. And so just to sum everything up and give you some take-home messages, most women in this country do get screened, about 80%. Most women who get screened too often. And there is a downside to screening too often. It's not just, hey, if some is good, more is better. It's just the opposite. We should really focus our efforts on those women who have never been screened or who have not been screened in more than 5 years or who rarely get screened. That's where we're going to prevent the most cancers. As far as what test to use, the HPV screening is the preferred option until there's more availability of HPV screening as the primary test. We do recommend co-testing as the next preferred test, and it is extremely safe to do either HPV testing or HPV plus testing every 5 years. It's as safe, if not safer, than doing a Pap test alone every year. And yet the Pap test alone is recommended every 3 years. And just to let you know, these guidelines are based on a review of well over 10,000 scientifically reviewed articles in the literature and have broad consensus of 25 or more national organizations and Canadian and others who also look at cervical screening. Thank you.
Thank you very much, Dr. Saslow. And please note, those who are tuned in live today, you can submit questions at any time using the Q&A box at the bottom of your screen, and we'll try to address as many as we can during the panel discussion portion of the event. Next, we will have Dr. Carolina Aristizabal discuss her work and experience supporting and the gynecologic health and wellness of her patients and addressing barriers to access and mitigating cervical care. Thank you, Dr. Aristizabal.
Thank you, Erin. Thank you, everyone, for having me. Good morning and good afternoon for those of you who are on the East Coast. So I'm going to talk about today about cervical cancer and the disease scope and burden. Let me move forward. So this is the outline: gynecologic health and wellness, also how does cervical cancer affect women across the life course, and how to address barriers to access and quality care. So in terms of gynecologic health and wellness, it's very important for us to understand that gynecologic cancers include not only cervical cancer, but also some other diseases such as endometriosis, fibroids, ovarian cancer, pelvic masses, uterine cancer, vaginal cancer, and vulvar cancer. Unfortunately, there is a low rate in cervical cancer screening in the US, and the total number of cancer screening tests, according to the Center for Disease Control and Prevention, the CDC, received by women through their program of cancer early detection declined by 84% of cervical cancer during 2020, as compared with the previous 5 years averages. So the prolonged delays on screening related to the COVID-19 pandemic we are facing may lead to delay in diagnosis, poor health consequences, and an increase in cancer disparities among women that already are experiencing health inequities. So it is recommended, as Dr. David just mentioned, the routine screening every 3 years with a Pap test or every 5 years with a Pap and HPV co-test, which ensures precancerous changes are caught early and also allows those changes to be followed more closely or treated. So how does cervical cancer affect women across the life course? In addition to lower than expected screening rates, researchers have also found that some racial inequities are presented in people who is getting screened. So for African-American women, for example, they were 50% less likely to be up to date on cervical cancer screening compared to white women in 2018. And the low screening rates continue to be like that. Asian women, for example, were nearly 30% less likely than white women to be current on screening. So these racial disparities are especially concerning. An estimated 13,240 new cases of invasive cervical cancer were diagnosed in the US in 2018, according to American Cancer Society, and another 4,000 women died from cervical cancer last year. So in terms of policymakers are often forced to view women's health by issue areas, such as cervical cancer, breast cancer, chronic disease, or pregnancy. So a better way to understand women's health, it really involves looking at a woman's life comprehensively. So women's health begins at birth. In early childhood, health depends on proper nutrition and the physical activity that we do, and in our proper immunizations. Then as a girl moves into a teen and early adult years, awareness and prevention and treatment for sexually transmitted infections become a concern for policymakers. So this policy also needs to address a variety of reproductive issues. Then as we women grow older, our health needs change. So the management of chronic diseases becomes vital, as does screening and knowledge about this type of diseases, such as cervical cancer and a variety of other conditions. Another factor that we have to consider is mental health, which throughout the woman's lifespan, that greatly affects our overall health. So all of these factors are imperative for us to have them into account when referring to women's life course. In terms of addressing barriers to access and quality care, then we have found that women experience unique healthcare challenges and are more likely to be diagnosed with certain diseases compared to men. Some chronic diseases and conditions such as cancers, heart disease, and diabetes are the leading causes of death for women here in the United States. And it is estimated that cancer kills more than 250,000 women in the United States annually. So access to preventive services and raising awareness about symptoms and risk factors for cancers is very important, and they are very important components of prevention and early diagnosis, especially for cancers such as cervical cancer, breast cancer, lung cancer, colon, and skin cancers, which are largely preventable. Some states have taken some legislative action to require the human papillomavirus vaccine for pre-adolescents, girls and boys, to prevent cancer, or have provided funding to make it more readily available. Women with cervical cancer abnormalities can experience some barriers to timely follow-up care, resulting in delays in cancer diagnosis. So the most frequent barriers that occurred are considered at the intrapersonal level, such as fear for having a medical consultation, or some insurance issues, such as lack of health insurance. while the other type of barriers are considered institutional level barriers, which appear, for example, when the system has problems to schedule care. So usually these are the most commonly recurring over time. So for Latina women, for example, they have reported barriers more often than African American women. So these differences in race and ethnicity and unemployment status are associated with different types of barriers. So compared to African American women, Latinas are more likely to report an intrapersonal level barriers. Unemployed women, for example, are more likely to report institutional level barriers. African American and Latina women have higher incidence and mortality rates for cervical cancer than non-Hispanic white women. These observed disparities are attributed to a number of factors, including delay of follow-up care, abnormal cancer screenings. So the figure of patient navigators appear to be able to easily resolve these intrapersonal level barriers. Their programs can assist in assuring timely follow-up care, but this patient navigation program need to be ongoing so that the system level barriers can really be addressed in our country. And with that, I conclude my presentation. Thank you for your time and for your attention.
Thank you, Dr. Aristizabal. Again, we invite attendees to submit questions using the Q&A box at the bottom of their screen, and we'll try to address as many individual questions and common themes as possible during this portion. I invite a panel, Dr. Saslow as well, to share, turn on your camera. And to open up the conversation, let's circle back to the HPV and Pap tests. What about the Pap tests, or rather the HPV, makes it less robust than the HPV test?
So the Pap test collects a sample of cells from a woman's cervix, and then those cells, we look for changes in the cells and how they appear under a microscope to see if they look not quite normal. So they could be precancerous, even cancerous. So if somebody goes in for a Pap test today and a sample is taken, the test result will say, does this person have any abnormal looking cervical cells today on the day we took the test? Now, the abnormal cells that we're most concerned about are the abnormalities caused by the virus HPV. There can be a whole host of other abnormal reasons for abnormal cells that are not clinically important. When we do an HPV test, we're looking for the HPV virus. The HPV virus we can detect sometimes years before it changes the appearance of the cells. So you're really giving yourself years of advance notice on whether or not there might be some precancers that are going to happen or cancers that are going to happen. So that's one advantage. Another advantage is, as I mentioned, the Pap test is going to detect a lot of abnormal looking cells that are not of concern. So that would be called false positive, things that might lead to diagnostic tests that are unnecessary. And then next, the HPV test can also tell you, particularly the one that's used for HPV screening alone, which type of HPV. So I mentioned there are about 15 types that cause cancer, but there are 2 or 3 that we're most worried about. So half of all cancers are caused by one particular type of HPV, HPV 16. And the HPV test can tell you not only does a person have HPV or not, but does it have the particular type that is most concerning and most likely to lead to cancer. And then finally, it can risk stratify. If somebody has HPV at their next checkup, but 5 years ago at their last checkup, they were HPV negative, that person is at much lower risk than if the person previously had tested HPV. So those are just some of the reasons why HPV is superior. It's easier to get a sample. We can do the self-sampling. It's a much more sensitive test. And so there are just many advantages to it.
And Dr. Carolina, you know, the Pap test, I mean, the HPV test, Pap, either way, it requires, you know, every 3 to 5 years. And that's quite a bit of time to keep track of. I know you go in, they're like, when was the last time you got it? I don't know, right? So when your program, you know, there can be, you know, barriers to access routine care. We definitely seen some issues with COVID and non-emergent care. But what steps has your program taken to help women stay on track or, you know, on top of their screening?
Irene, we have at USC a program that is called Tiempo, which is basically a cervical cancer prevention campaign that we use not only for women, also for boys, since the HPV vaccination is now available for boys and girls, right? For them to be able to be aware
I think the
of the
video,
jacaranda. Sorry, what?
I think your video paused and you're just saying boys and girls. And so if you
Oh,
can.
I'm sorry. Yeah, so we use a cervical cancer prevention campaign, which is called Tiempo. And what we do with this campaign is basically for all the women to remember annually with the blooming of the jacaranda tree or the jacaranda tree. That is a very wonderful purple tree that blooms between April and June every year. So we remember through this campaign, all women to get screened with the Papa Nicolau test, and also to ask for an HPV test. Since we are facing this type of low of access of care with the pandemic, then we have also, and we offer also a call center for people to be able to make phone calls, to receive phone calls, and to just program their consultations to get screened yearly.
Thanks. So how can we increase access, and this is either for either you, access to the HPV primary screening for diverse patient populations and making sure that we are addressing that shift from Pap and co-testing to primary HPV testing?
So I can start. Sorry, did you want to start?
No, it's okay. Go ahead, Dr. David.
So I mentioned that we're doing a huge transition plan, which is what other countries do, and the US doesn't tend to do this. And so as part of that transition process, we have work groups, one of which is specific to patient needs, including patient communication needs. One is for provider and provider education, and one is for specific to the move from cytology alone. And so we do know that, for example, Parkland is a huge system in Texas that went directly from Pap test to HPV test without going through co-testing. And they serve very diverse and low income, under-resourced communities. So we're looking at that. We're looking at insurance. So an HPV test alone is going to cost less than an HPV plus a Pap test, plus there's less follow-up. And so if we keep the cost down, if we address the insurance issues, we're addressing the IT issues, we're addressing the laboratory issues. And really, I think what's going to push it the most is if all national guidelines align. If the U.S. Preventive Services Task Force, the American College of OBGYNs, and the American Cancer Society, which are the three main national guidelines, all say the strategy is use HPV and do not use Pap or co-testing, then that will be the only choice. It will be the same screening available for everybody. And then in addition, if and when the FDA approves self-collection, that will further expand access to people who are not getting screened for various reasons.
Thanks. Carolina, you had something you wanted to add?
Yeah, besides following the guidelines, as Dr. Devi mentioned, what we do is to provide health education. We have broad programs on health education, and we provide different workshops, for example, in English and Spanish, addressing what is cervical cancer. And we also provide information regarding the importance of getting screened and the importance of getting HPV vaccination for boys and girls starting for the 9 years of age. So we provide these workshops on a daily basis through one of our NCI programs, which is called Non-CHE, and a community health educator that we have. She's providing to all LA County area these workshops online and in person also, so that we make sure to address all of these barriers that not only our Latina women faces, but all of our minorities populations that we serve. Because, and following, sorry, Irene, with the different questions that are there, someone is asking, for example, if I have to mention one of the barriers, what barrier I think is the greatest, and for sure something that we all face is the lack of knowledge on these different topics, and the lack of knowledge as to the availability of these screening tests out there that in many areas are provided for free to our communities. So that is why we want to increase their knowledge and their awareness in these health issues, so they become aware of what are there, what services are there provided for them, the way that they can access for it for free. And then in this way, they can for sure increase access and screening, and we can increase also vaccination intake and prevent this type of cancer.
Thanks. And actually, is it possible in the chat, can you put the link to that resource, the website, to get those resources? That'd be great for those.
Absolutely.
We'll make sure to mention it verbally as well. So it came up, you both have touched on the self-sample. What is that collection like? You know, how are you doing self-sampling? Because we know, for example, when you do urine, that's very easy, but is it that easy to do a self-sample?
So first of all, it's not being done yet, only as part of a research trial. But there have been trials going back many, many years that all show that this is an effective way to do screening. Basically, there's a kit that would be sent to patients, similar to when you collect stool for a colorectal screening. You get a kit from your provider or your health plan. It would also be available through pharmacies, not online. It would be through prescription, and there would be instructions, which is basically it's a swab. It's similar to the speculum exam without the speculum. It's similar to a small tampon, where a woman will follow the instructions to get the sample, and then similar to the stool testing, there will be packaging with directions as to where it should be sent, whether it's sent directly to a lab, or if self-collection is done in a doctor's office, it could be handed then to the nurse or whoever's there.
We've definitely seen, you know, at-home testing, particularly during this pandemic, as a way of, you know, getting it to individuals who aren't able to, you know, get out to a doctor. And so that being something that's on the horizon as far as, you know, improving some access. We have a question that came in. What would you like to see from the private sector, maybe test manufacturers, insurance companies, to support addressing other barriers that we've mentioned as far as access or implementation of care?
Do you want to take that one?
Okay.
Okay. So from the Cancer Society, again, we're in a state of transition when it comes to the HPV test, and so, you know, follow the guideline. I guess that's the first thing. People think they know best and that guidelines are made, but not for my patient. So follow the guideline. Don't screen every year. Know what test you're using. There was a question here somewhere in posted about which test to use. There are 4 or 5 HPV tests that are FDA approved, but only 2 are available. I'm sorry, only 2 are approved for HPV alone. So if you're going to be switching or you're already switched to the primary HPV screening, you have to use either of those 2 tests. What else? And then for insurance, insurance, we're really going, there are a lot of guidelines for insurance. So they have to, because of the Affordable Care Act, they have to cover whatever's recommended by the U.S. Preventive Services Task Force with what's called an ARB recommendation. So currently, we know that almost all insurers cover all of the different cervical screening methods, and that if and when the task force aligns their guidelines with the Cancer Societies, it's unclear whether insurance companies will stop covering the others or just leave it there and people just won't use it. And so that's one of the conversations that our insurance work group is having.
And also, I'm sorry, also for to add to that, for those people who doesn't have access to health insurance or that they don't use any provider, they can call or search online to their local public health agencies and look for different services that are provided for free, and ways and instructions and guidelines for them to also get enrolled under the Affordable Care Act. So that they can get access to health insurance and then start getting screened and follow up with a primary care physician.
Is there a barrier for resource for primary care physicians to be able to have the HPV test? Is there any advice you'd give to them?
So everything is interconnected. The provider can order those tests that if they're part of a larger practice or a large health system, that system offers. So they may not have a choice. They will send samples to the lab. The lab that they use or that their system uses may or may not have the equipment and, you know, the capacity and offer to do the types of HPV testing that are approved for primary HPV. That's changing, fortunately, because one of the tests, the machine that is used, it's a very expensive machine, so you're not going to have every lab go out and go get it, but it's also being used for COVID testing, and so there's a lot more availability of that equipment, expensive equipment. I don't know if it's all being used for COVID testing right now, and so access will change, but that's going to work in our favor. And so another thing that I hear that's really discouraging is that it's not so much that certain facilities or offices or health departments only offer cytology alone. It's at least as common that certain providers that for some of their patients, they have to offer Pap because either the patient is paying out of pocket and it's cheaper, or there are other, so it's not just the provider can offer either one, but depending on the patient, they may have limitations.
Thanks for that. I think it's important sometimes, like there are some challenges that the providers face, even though they want to be able to offer some of the advanced opportunities or some of the innovations. And so speaking to that, we definitely have a better appreciation for it's a whole ecosystem that all has to be able to work together, and we're pushing forward for doing
Yeah,
that.
including, we have so many different electronic health records, so we can't just change them all at once to do what we want them to do, to set reminders at the new age and the correct frequency and the right test.
There was another question that came in about the harm, because we say the Pap test, HPV test is great. It allows you to do every 5 years. And we've mentioned, and with that infrequency, it also can catch earlier. But every time you go in, I don't remember if I got it 2 years ago or 3 years ago, we'll just do it again. What are the harms in doing it regularly every year, even though it's not necessary, but is it actually harmful? What are those things, if you can speak to that a little bit?
Yeah, so I mentioned that almost everybody gets HPV, and some people get it more than once. HPV almost always goes away on its own. Otherwise, we'd all have cervical cancer, right? And so if we detect it, usually it's going to go away on its own. So we have to wait to give it a chance to do that. And there are a lot of cancer screening tests that you do want to do every year or every 2 years, like mammograms. You wouldn't want to wait 3 or 5 years because breast cancer grows quickly. But for cervical cancer, first you're finding HPV before it's even changed the cell, before it's even precancerous. Then you've got these precancers that often take 10 or 15 years to progress to cancer. So most people get HPV in their teens and early 20s, but most people don't. I hope I said that's when they get HPV. Most people don't get cancer, cervical cancer, until their 30s, 40s, or 50s or 60s. And so you don't want to be finding infections that will go away on their own or not cause precancer or cervical cancer, because otherwise you're going to be doing colposcopies, biopsies. You're going to be cutting out people's cervixes, especially young women where HPV is most common when they haven't had their babies yet or finished having babies. And so then you get into even more severe harms of low birth weight babies and not carrying to the pregnancy to term. And even just having to go back to the provider because my HPV test was positive. Do I have cancer? Oh no, who gave it to me? When did I get it? Am I sick? Do I have to be worried? I need to come back next year or in 3 years to get tested again. I'm positive again. Do I need to come back? Do I need to come back? When in my longer slide sets, I show a revolving door, because that's once a woman tests positive in cervical screening, it's often a revolving door to her gynecologist's office. And so people don't want to keep going back to get all these extra unneeded tests, to have the anxiety, to possibly have multiple biopsies that could harm them, abnormal bleeding, cost to the health system, etc. So yes, there are a lot of downsides. And again, 5 years is very safe. I mean, would you want to get a colonoscopy every year? For colon cancer, those are recommended every 10 years. And what we need to do, and you asked about the private sector, the insurers, the IT, what we need to do is get better reminder systems so that it's not the patient who has to keep track of whether it's been 3 years or 4 years or 5 years since their last test.
That is actually a really good wrap up and summation with that. And so I do want to give Dr. Aristizabal an opportunity as well to kind of give some final comments before we wrap up. We have patients, researchers, clinicians, policy professionals, industry that join these events or watch our videos later. What takeaway would you recommend to help any of these groups or all of these individuals support screening and prevention of cervical cancer?
Irene, I think that the most important point to take away from today is cervical cancer is absolutely preventable. We have the screening methods to have to be able to be tested frequently, and we have also the vaccination available, the HPV vaccine, to prevent it. for our little boys and girls since they are 9 years of age. So please go talk to your primary care physician. If you are a primary care provider, then please remind to all of your patients, right, about the availability of these vaccines. And in your communities, your neighbors, with your friends, with your family members, just remind them of how important it is to prevent this disease and how important it is also to be able to take the vaccine and to be able to go and get screened and check and to talk with your primary care physician on a regular basis.
Thank you so much, Dr. Aristizabal. Thank you, Dr. Saslow, for being an amazing panel, for your time and your insight to talk about this important topic. And thank you to Roche for their support of this event and the SWHR Value of Diagnostics within Women's Health series. We're looking forward to highlighting more areas of women's health that benefit from innovations in screening diagnostics. And in April, for STI Awareness Month, SWHR will be focusing on screening and detecting sexually transmitted infections to prevent further spread, especially during pregnancy. We invite you to connect with us on social media and visit our website, www.swhr.org, to register for future events, download women's health resources, and sign up for our newsletter. We'll be sending out an email with a recording of today's webinar to all registrants, so please be on the lookout for that. Let's continue the conversation with hashtag SWHR Talks Diagnostics, and for today's topic in particular, hashtag SWHR Talks Cancer. Thank you for joining us. Have a good rest of your day.